Hi, everybody. Thank you so much for joining us. We are going to get started as quickly as possible because we want to make use of every moment that we have. For those of you who don't know me, I'm Aurel Jackson. I'm the newest member of the team. I'm the Director of Engagement, and I'm joined today by Rachel, who can wave to us. Rachel, our COO, and Brian Romy. Brian, can we get a wave from you? And of course, our fabulous founder and CEO, Dr. David Sabgir. So welcome to all of you. It's wonderful to see so many of you joining us. Thank you for sending all your questions ahead of time. So just to give you an idea of how this is going to move forward today, David is going to give his presentation. I'm going to basically ask him some questions so we can get the conversation going. And then we're going to go to the questions that have been sent in prior to the call. So thank you very much for sending those in. There are a lot of questions, but that doesn't mean you can't still ask us more questions. Use the chat box, but we'd suggest, just so that you have some privacy, that you when you chat, you choose to send your chat message to the host, and we'll just read the question out without your name. And then the same for those folks who are joining us on Facebook. Go ahead and put your questions in the chat there as well. So, David, are you ready to get started?
Yeah, I'm happy to be
Okay.
here.
All right. So, David, you've called this the behind the scenes tour. So when you and I were talking, you said to me, you're really going to go through some of the ABCs of heart disease and sort of give us a behind the scenes tour of what heart disease is and the things that we can do to protect ourselves and protect our wonderful hearts. So you ready to get started? I believe the first letter is A, so go for it.
Yeah, awesome. Thank you. And just a little bookkeeping. I'm outside. I like it better out here. If it gets sparky or we're right next to a park, I'll may shift and move inside. I see so many friends on the screen, so thank you for being here. And yeah, so probably 15, 20 minutes of this, but really we want you to ask your questions. This to me is a cocktail party, although I don't have alcohol, but just feel free to just use me and abuse me with your questions in the chat box, and we'll go. So I have a list in front of me about 20, 25 topics I'll go through pretty quickly, are the most commonly um, asked questions at the walk or in my cardiology office. And um, my answer is not the end all, but I've looked into this a lot, and please check with your doctor as well. Rachel, Brian, and Rel, thanks for doing this. And let's talk about aspirin. Seems like a really good first one. There's primary prevention and secondary prevention. Secondary prevention means that you've already had an event, maybe a heart attack or stroke. If that's the case for my patients, automatic, this true really for all cardiology physicians, 81 milligrams of aspirin, or some studies show if your weight is over 160 pounds, 162 milligrams, which would be 2 baby aspirin or 1/2 of an aspirin. And again, if questions come up, fill the chat box and we'll get to them. Primary prevention, that has shifted. For a while, we didn't really know what to say. Over the last year, it's become more and more clear, year and a half, that it's not necessarily recommended anymore to take a baby aspirin for prevention. There's all kinds of um, exceptions, but for the most part, no. Another A, abuse, tobacco abuse or alcohol abuse. So tobacco use, I doubt we have anyone who smokes on here, but nicotine is extremely addictive, super hard to beat. It cuts our life short by about 14 years on average. Best thing to do is pick a stop date, pick the reasons why you want to do it. If there are questions on this, we can delve into it. But um, we all know smoking is The worst thing we can do for our health. So getting over smoking is massively important. Tobacco, or excuse me, alcohol use, that has shifted. When I was in med school 5 million years ago, it was one in regards to our health in general, one is better than none per day. Two, one being a drink, which would be about 4 ounces of wine, 12 ounces of beer, or an ounce and a half of uh, spirits. So again, one is better than none, two is better than one per day, and three is worse than none. Things have shifted, things have evolved. Now we know that alcohol does increase overall mortality in any amount. So this gets sticky. A lot of us may partake in social alcohol. It's a good thing to speak about with your physician. You're probably going to get sick of hearing me say that, but um, where I fall is it does lower our cardiac risk if it's in moderation. And moderation has now dropped down over the past year, again, to 1 for women, 1 for men. Above that, not recommended. And, overall, it's not recommended for your health, but it's not safe for your health, but neither is driving, and people have to drive. And forgive that analogy, but that was one that came up a lot in the press. Move on. Blood pressure, the silent killer. And it's called the silent killer because we don't feel it for the most part. Again, fill up that chat box and with specifics. We generally shoot for 130/80. The top number is called the systolic. We like that in the 120s or lower if possible. If it's above, there's no need to panic. We have plenty of time and plenty of medications to drop that down. We prefer something we call TLC, or therapeutic lifestyle changes. And that's, of course, walking, maintaining a normal weight, a diet high in fruits and vegetables. Um, that's a really good thing to do. We have so many different blood pressure medicines we can use. And the reason we want to knock down blood pressure is it is one of these major risk factors, along with diabetes, low cholesterol, or excuse me, a low good cholesterol, a high bad cholesterol, and smoking, among some others that we can really eliminate heart disease. And one thing I want to drive home, the ball is in our court with this. Heart disease prior to COVID was the #1 killer. This year, it's been taken over by COVID, and please get your vaccine. But it doesn't have to be that way. Truly, the ball is in our court, and we can get, the official number is 83% reduction, but a lot of cardiologists I respect believe it could be much higher as far as what we can do to prevent it. So blood pressure, there's uh, 3 main medicine classes. Those are ACE inhibitors or ARBs, diuretics like hydrochlorothiazide, or calcium channel blockers. Cholesterol. HDL is the garbage. I hope you guys can hear me now. I said HDL is the garbage man. It goes in to the plaque, which is on the inside of our vessels, and takes the LDL, the bad guy, that we want that number as low as possible, and brings it to the liver to eliminate it. There are no medicines that can increase our HDL, but we can do a lot with exercise, fruits, vegetables, soluble fiber, to really get that HDL up. We like it above 40 in men, 45 in women. And if you can get it above 60 or 65, you subtract another risk factor. So that's HDL, or happy cholesterol, or good cholesterol. LDL, we want that definitely below 190. There's all kinds of situations there. Again, feel free to chat if you have a specific question with that. Statins, are very a significant advance in medicine in the last 25, 30 years, and I strongly recommend them. If you're tolerant of them, 95% of our patients are. Diet. We get asked that a lot. 7 words: eat food, not too much, and mostly plants. That is all we need to know. Happy to delve into it, but diet books, diet, all that stuff, never seen anything last except something recently is getting a lot of good data, and that's intermittent fasting, which is not a diet. What I love about intermittent fasting is no one's making any money off it. You just, I mean, we can happy to answer questions on that, but it can simplify our lives, lower our calorie intake, and there are a lot of good studies. The only diet I've seen since I've started back in the 1930s where we can really make a significant difference, and the data is wonderful. Personally, I'm about a month of doing 16 hours, not eating, 8 eating, and I have the weakest willpower and I'm doing it. So if I can do it, trust me, anyone can do it. And I do recommend it. In addition to diet, a plant-based diet is the diet I recommend. I'm realizing I've totally cut you off, Aurel. This is horrible. I'm just working my way through the alphabet. Exercise is E. Diabetes is another D, a major risk factor. We like that. Hemoglobin A1C, which is a measure of how well our diabetes is being treated. We really like that number below 7. That's an important number as a risk factor. E, exercise. Number one thing we can do, it's not only, we have some real exercise experts on the call. Thrilled to see you there. Nothing better we can do. If I had all my patients walk at a moderate pace for 150 minutes or more a week, I'd be out of business, and I'd be happy for it. That's E. F, family history, definitely a risk factor. I think it's a little overstated, and it's a lot of times confounded by the fact that family members may smoke or carry excess weight or have diabetes and have other risk factors, but it's definitely a real thing. Typically, it's a first-degree relative. If it's a mom or sister under the age of 55, is very significant. Some books say 60, and a dad or brother, first-degree relative, around that age as well. Sometimes, yeah, women, I misspoke. Women, it would be more 60, 65, men more 50, 55. But that's definitely something to be aware of. But a lot of us have a family history of coronary artery disease, and we're still in that camp of people that can reduce it by 80 to 90%, reduce our odds, which is a big number. That's F. G, group activity. Social connection is something that we have learned through the walk over the last 16 years is incredibly powerful, and it translates into stats that we never would have guessed, like reduced admissions to hospitals and illnesses. So it's really important to participate in a group activity. We would love for it to be walk with a doc, but if it's not, or in addition, my mom is in a quilting group she loves, or and anything where we can create that social connection, there are strong health implications. H, hope. We love positivity and having something to look forward to. That's very important. We've got about 4 minutes. I want to touch on vaccine. Please get your vaccine. I get asked all the time, should I do it? I have this, I have that. We're basically recommending it for everyone. There's one additive in the vaccine that a very few people are allergic to. If that's the case, please speak with your doctor. And of course, you'll speak with your doctor about any of this stuff, but I strongly recommend you get the vaccine. All of us, um, well, Brian and Rachel are too young, but um, I've had it, Arel's had it, went great. Sleep apnea. There are, I think, real quickly, there's an acronym, STOP BANG. Sleep apnea is an epidemic that's not being recognized, and it travels with carrying excess weight. And we know that about 70% of the US right now is either overweight or obese. So therefore, a lot of sleep apnea. Stop bang. If you have 4 of these 8, snoring, tired during the day, the one where the patients I have that have overwhelming, horrible sleep apnea come in and say, I am wiped out. I don't have it anymore. I'm exhausted. O is observed apnea. So someone has seen you stop breathing. That's the definition of apnea while you're asleep. P is blood pressure. So if you have an elevated blood pressure, that's one sign that you may have sleep apnea. And then bang is BMI greater than 30, age greater than 50, neck size greater than 16, 16 and a half, and gender male. If you have 4 of those, probably a really good idea to get tested. And the bright side is our patients that go kicking and screaming, they don't want the mask, they don't want to sleep outside their house. I get that, but so many of them love it and it transforms their lives. And I'm not making any money off it. So please just go for it. Supplements, I don't like it all. Feel free to ask questions, but I have not found a supplement. Someone really smart once said garlic is really good on pasta, but it doesn't do much for the heart. There was a question on eggs. Egg whites, great. Eggs it was a PLOS study last month that egg yolks, and that data is a roller coaster ride, as are a lot of things like, alcohol and coffee and aspirin. But right now, egg yolks are not the most popular child. Egg whites are good. They have 4 grams of protein instead of the 6 if you include the whole egg. And the most recent study on eggs, the big one, says keep those egg yolks to a minimum. I know that's not popular. Fish oil, our practice used to recommend strongly a long time ago. Unfortunately, no health benefits from a heart standpoint, maybe some other stuff, but especially if you eat fish once or twice a week, absolutely no need for fish oil, in my opinion. Coffee, good. And we're at 5:19. And I realized that was a crazy pace. It gives me 1 minute to say how grateful I am that you guys joined us. And use us and abuse us over the next 40 minutes. And I hope I wasn't on mute for the last 20.
No, you weren't. So thank you. Thank you, David. That was really great. And I'm going to start on the questions now. Please, I see some of you are putting questions into the chat. We're going to start with the questions that you sent in ahead of time, and we'll get through as many of the questions as we possibly can. And I know some of the time David is going to say that's a question you need to ask your doctor. But we'll go through them and he can answer that for you. So let's start with somebody who says they had a mitral valve repair in August, and they want to know, why is a beta blocker necessary after surgery?
Okay. So I don't know if you're still on a beta blocker. I saw this question ahead of time. Thank you. That's really helpful. I looked through, there are no studies suggesting that you need to stay on a beta blocker long term. And that was my gist going into this really good question. Immediately post-op, there are some studies showing it can reduce atrial fibrillation, which is a very common rhythm issue after surgery. It can also, the heart can tend to get a little bigger from all the adrenaline and stress. So beta blockers perioperatively are very common. My personal take is that there's no absolute need to be on it longer than, say a few months out.
Okay. From the same person, they ask, what are your top post-surgery recommendations when in-person cardiac rehab is canceled due to COVID, as well as in-person physician appointments?
Yeah, so what a, tough year made, what's normally a difficult situation more complicated. My recommendation for that is find out where they are with Frony. Thank you. I love you. I think you're the best. So thank you. That makes my day. What I would do, so walking is incredibly important. You can do, to me, poor man's cardiac rehab, making sure you're walking, making sure you're paying very close attention to your symptoms. Let me take a half step back. Cardiac rehab is real. A lot of the stuff as I went in, I tried to figure it out. Sleep apnea was another thing. Is this just a hoax for doctors to make money? It took me a few years to realize, no, it's not. Same with cardiac rehab. There's very good data. I was head of my cardiac rehab in the past. Very important. Walking every day. After you check and see if they're open again. If they're open again, I would go do it. Dietitian consultation. There's so many things in foods that we don't know about. Those are really the most important things. I'll stop there.
Okay. And then the final question from this particular person is, what is your opinion on heart patients ages 60 to 64 receiving the AstraZeneca COVID vaccine?
Yeah, so absolutely. I've gotten the question, which one should I get? In Ohio, we're not allowed, or at least in our system, we're not allowed to pick. And I don't think there's any difference. I don't know what I would tell people if they ask. And yes, yes, yes on the vaccine. There was no secret meeting with all the doctors to say that. It's just really important. COVID, as we know, is the #1 killer this year. I've seen too many horrific stories, both in the hospital and out, and I don't want anyone to have to deal with that.
Okay, thank you. So one of the next question is really about eggs, which you've answered. So thank you for that. The next question from the person who sent these in, they ask, for older adults 60 plus on a plant-based diet, is it advisable to cut out whole milk entirely, since almond milk and others have very little protein?
Yeah, so protein, important, great question. Personally, I'm a wannabe plant-based. I'm working my way, and thanks to my wife, we're doing better and better. She's making purple carrot right now, which is not a sponsor, but their food is incredible. You would never know. I love plant-based for a lot of reasons. That said, to me, it's everything in moderation. And Sarai Stanchik, who is a good friend of the walk and did the movie Code Blue, she talks about what Colin Campbell shares, and the China study. He's an icon. It's 10% is my impression, that 10% of the time not plant-based. If you love whole milk and it's something that you get emotional about it, it brings back all kinds of warm memories, absolutely go for it. The protein we need is 0.8 grams per kilo. So for a 70-kilo person, about 154 pounds, that's 56 grams of protein. You're probably getting enough protein in other sources, but everything in moderation. I found if you cut stuff out, 2.5 months from now, you're going to be so angry at the plant-based diet because you can't have your whole milk, you'll give it up. And that's what I've experienced myself and seen in patients. So have a little whole milk.
Okay. Now a question about statins. Do statins affect memory function when taken over a long period of time?
Yeah, so I think the most important thing is it's reversible. So if God forbid right now you're on a statin, you're convinced it was memory loss, the label on some of them says less than 2%. but I've learned through experience, labels are usually right, but sometimes you're like, that doesn't fit with my experience. This does fit. I would expect the wife or the husband to say, he's forgetting ever since you started him on rosuvastatin or Zocor or Lipitor, he's not the same. The memory's not, I don't hear that. And to me, that carries a lot of weight. So my recommendation is, because they're so effective, for example, every time you lower your LDL 40 points, and a statin should lower it on average by about 50 to 60%, which, could be 60, 80 points or more, you reduce your risk of a heart attack or stroke by 25 additional percent. So it's very powerful, very successful medication. So I would try it. And if you feel your memory's affected, then thank God it's reversible, and try something else.
Okay, thank you. Our next question is, what causes the heart to race, beat really fast while sleeping or waking up in the night with a racing heart?
Yeah, it's a great question, and there are a lot of possible things. So the most benign, we do place a lot of 24-hour, 48-hour Holter monitors, and we see that heart racing a lot of times can be a normal, called sinus tachycardia, and that is a normal heart racing, like the train is on the tracks, is just going faster than 100. So that's possible. Then there's atrial fibrillation is another arrhythmia. SVT, or supraventricular tachycardia, meaning a fast heart rate starting on the top part of the heart, that can happen. And the best way to do it is, what I tell my patients is, we need to see it on film. So wearing a monitor. There's also a third-party device now called Cardia, Kardia. I think it's about $100, which is expensive, but you get to keep it, attaches to your phone, you put your thumbs on it, and it records your rhythm. Of course, the new Apple Watch, and I'm sure others, do this as well, and they're pretty good. Like, our cardiology practice looks at those recordings, and we trust them. So that's another way to figure out what it is, and then we can figure out from there which road to go down.
Okay. Next question is cramping in the feet or in one foot at night a need for concern?
There are more causes than not are non-cardiac. It's typically related to something structural in your foot, either a shoe issue or too much stress on your foot. There's stretches, it could be dehydration. Typically, if it's a circulation problem, which I imagine the question may be getting at,
Mm-hmm.
it can present various ways, and it could be a circulatory issue. It's just unlikely. Typically with circulation, what we'll see in the office is cramping in the calves. It's called claudication. So something where you walk for a distance, it can be any distance really, and smoking's a major risk factor for that. It's rare to see it in non-smokers. And then it goes away when you stop, picks up again when you move. So hopefully that helps.
Okay, so if one is concerned about that, if it's happening sort of frequently, we would want to check with our physician, right?
Absolutely.
Okay. All right. So the next question is about cirrhosis and COVID-19 treatment, remdesivir. And the question is, what effects does it have on the liver? Is there other treatment besides remdesivir that will treat COVID-19?
Yeah, so I saw that one ahead of time. It's ideal pretty much here. Now, I looked it up, and there are no studies with remdesivir with hepatic cirrhosis. So the bottom line is, there is no answer. There are a couple case reports where it's been given, but they did not study it. There are a lot of options for COVID-19 that don't involve remdesivir. They work from different pathways. Dexamethasone, we've heard about, very strong steroid that was able to reduce mortality, deaths from COVID-19 pretty significantly. The antibodies are working. Convalescent plasma has worked. So there's lots of things, but the best thing, get the vaccine, don't get the virus.
Okay, good point. All right, next question. How do you determine the appropriate level of moderate exercise to increase heart strength?
Yeah. So we have one of the people on the call is idol of mine, Joan Dorn, who is the author of this study, but so it feels awkward. But what I push for in my office is 150 minutes a week or more. My understanding is the guidelines in 2008 said it had to be at least 10 minutes. The updated in 2018 says just anything. You don't need that heart rate elevated that long. That does, like, it encompasses everything we do. It makes our heart more efficient. You're right. So 150 minutes a week or more is miraculous.
All right. The next question is, how is venous insufficiency related to heart disease, and what are the best treatments for venous insufficiency?
Yeah, so the two main causes of venous insufficiency, like when our veins in our legs and our arms have valves, and if those aren't working as well, the blood clots and varicose veins are the two most common reasons. The number 1, 2, and 3 treatment is compression, 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 and elevation. And if those aren't working, I recommend meeting with a vascular doctor. There's a branch of, or our cardiovascular doctor. There's lots of different things we can do.
Okay, great. The next question is about sleep apnea and Afib. So the person asks, or the person says, I'm diagnosed with Afib and take medication prescribed by my cardiologist. I activate my CPAP machine each night to address sleep apnea. Is there any chance that I will eventually overcome the Afib and get my heart back into a regular sinus rhythm?
Yes, there is a chance. And Afib and sleep apnea go hand in glove. One of my partners is an electrophysiologist, which is fancy for the doctor that deals with pacemakers, electricity ablations, Afib, and all that. He jokingly says every patient he sees with Afib, he wants a sleep study before they come to see him because they're so tightly related. You can dramatically reduce your frequency of Afib by doing this. So the bad news is Afib pretty much is there and it'll come out when it wants to come out. But the thing is, it may come out every day. It may not come out again for 15, 20 years. Ways to control it: keep the blood pressure down, sleep apnea, managing that. Those are two big modifiable things we can reduce to reduce the frequency. But there's also medications, and ablation has been very successful in getting rid of it. So while it's kind of in there, ablation will get rid of it at about 60% success. It'll never come back. But we hopefully just don't need that. There are millions of people walking around with Afib that don't feel it. And as long as you're on, if you meet the criteria for a blood thinner, and the most common ones are warfarin, Eliquis, Pradaxin, Xarelto, then it's really, you don't need to do much as long as the heart rate's controlled and the blood is thinned.
Okay, thank you. The next question, our person asks this. They said, I've had 2 ablations for SVT, 205 BPM.
Beats per minute.
Right, and have occasional PVCs. I've just been diagnosed with sarcoidosis, and the pulmonologist wants to send me to have a myocardial PET scan. I'm kind of scared. The sarcoidosis was found by accident.
Okay.
Anything you can do to help them feel a bit less
Yeah.
stressed?
So I'm not a, first of all, I totally get it. I hate doctors, going to the doctor. So I understand that fear. What I would say, a PET scan is, we do those. They're if that's the, you know, origin of the fear, they're very benign. Um, they're essentially a nuclear stress test, very safe amount of material, and they give us a lot of information. Now, another question, which, you know, feel free to ask further, or go further, but I don't, within that, the context of that question, I don't necessarily see a precipitating reason to get a myocardial PET scan. But if I were you, just, and this goes in general, hold us as physicians to, you know, hold us accountable. And it's very fair. And I get asked all the time, like, do I need that? Well, I don't get asked enough. Do I need this test? Tests are expensive. They induce fear, you know, and um, you may be surprised that the doc may say, well, it was more just to be safe, but yeah, I guess we could hold off.
Okay, so in other words, you're saying that we should feel comfortable having a conversation with our physicians and saying, why is the test, why are we doing the test? Is it necessary?
That's exactly right. And, you know, this is a Googleable list of 10 questions you should ask your physician. Bring, bring that, bring that with you. A physician visit, they're not doing you a favor. You know, they don't need to get out of the room in 3 minutes. They have time allocated, and these questions don't take that long. So ask them, do I need to be on this medication? You know, what is the cost of this test? They're very fair. So I'm glad that came up.
Great. Okay. The next question is, what are the symptoms of tachycardia and how is it diagnosed and treated?
Mm-hmm. So tachycardia is synonymous with fast heart rate. And a normal heart rate is 60 to 100. And so above 100 is classically what tachycardia is. You may not have symptoms. You may feel palpitations. Um, you may feel lightheaded. Um, you may feel anxious, but it's also, you know, what's the cart and what's the horse? Because you may, if you're anxious or stressed about something, as we all get, that may cause the heart rate to get faster. And again, there are plenty of ways to check your EKG as we talked about.
Okay, thank you. The next question is got a couple of questions rolled into this. So the person says, my sister has erratic blood pressure. Last week in the doctor's office, it was 203/105. 2 hours later at home, it was 166/92. 1 more hour, it was 135/79. She's journaling this for her cardiologist. She is on heart meds. She has a strong family history of cardiovascular issues. She works 2 part-time jobs, uncontrolled apnea. So apart from change in diet and exercise, is there anything else that she might want to consider doing?
Yeah, so the operative 2 words were uncontrolled apnea, right? So, you know, first, yes, blood pressures can be crazy. You know, the white coat hypertension is, you know, when you're in the office and scared like I am to see the doctor, your blood pressure goes up. So a really good idea to have a cuff at home, have recordings, check them, you know, and you'll be able to get an idea of probably a range of 20, you know, 120 to 140, 140 to 160, where you sit. Again, sleep apnea is a pain in the butt as far as getting the test and the costs and the fitting and all that, but it will lower your blood pressure. Of course, we prefer diet and physical activity, to reduce the odds that you may need it. We want to get your sister below 130. It's underutilized, in addition to weight loss and physical activity, but stress management techniques such as yoga, meditation, coloring books, whatever your thing is that puts you in your happy place, those are really important and underutilized.
Okay.
That said, the average American with hypertension, high blood pressure is on 3.1 medications. And the reason is, like your sister, without medicines, you may be 170, 180, 200, and the average blood pressure medicine lowers you about 16. So you may need a few. The four things to really live forever, if you will: not smoke, maintain a BMI or a body mass index, and it's easily Googleable how to do that, of 20 to 25, a diet high in fruits and vegetables, and physical activity. You can do those four things, you'll live forever. Don't quote me on that. I guess this is tape. Tongue in cheek, like if you do those four things, like life's a breeze.
Okay.
Chill out.
All right. I hope everybody made notes on that. All right. Our next question is, please give information on why a person would develop atrial fibrillation and what treatments are recommended when a person develops it.
Yeah, so atrial fibrillation, which is also called AFib, is very, very common as we get older, and their comorbidity. If you have, like, as we get to a certain age, the incidence or prevalence of this can be 20-25% of the public, and that would be, maybe over age 75, with also having coronary artery disease and hypertension. High blood pressure and age are the main drivers for AFib. You may have heard of holiday heart. I had a patient with this today, where if you drink too much alcohol, it can potentially put you into AFib, but it's very common. And but it's also, it can be, most everyone is asymptomatic. So it is recommended that if you're found to be in it for the first time, to get that cardioversion if you stay in it. After that, it's no longer, and it's been this way for a while, no longer acceptable or recommended to continue getting shocked on subsequent treatments, subsequent episodes. If your blood is thin, there are a couple massive studies about 15 years ago that have held up. If your blood is thin and your heart rate's controlled and you're asymptomatic, that's really good. Ways to prevent it: maintain a proper weight, keep that blood pressure down. If there's sleep apnea, again, address that. And don't beat yourself up if you get it. It's very common, very treatable. You're not, it's also very serious in that it can cause a stroke if you're not on a blood thinner, and your score, there's something called a CHADS score, which is another acronym. CHADS VASC is another, and quickly run through those: congestive heart failure, hypertension, age greater than 65 is a point, greater than 75 is 2 points, diabetes, or a stroke, or a TIA, which is a mini stroke that goes away in 24 hours. If you have any of those, you get a point or 2 points. V is vascular disease, and then gender is women actually have a point added. So if your score is usually 2 or more, it's recommended you be on a blood thinner. It will almost even out your risk of stroke to anyone else your age. So If your blood is thin, your rate's controlled, you're not going to, I mean, you're not going to drop dead from a heart attack. You're not going to drop dead from a rhythm issue. It's stroke is the main thing, and obviously very serious, and blood thinner helps a ton.
Okay, thank you. All right. The next question is, when should you get a heart checkup? I'm 62, and since COVID, my blood sugar readings are fluctuating from 130 to 170 in the morning. I see my primary care doc on the 1st of April.
Okay. So I'm sorry, when should you get a heart in related to COVID or just being 62?
So it's 62 and blood sugar readings fluctuating, I think,
Okay.
of the things. So
Yeah, so um, primary care doctors are, just about everyone I met is a very good gatekeeper. And if it were me, I would ask that question on the first, is this something where I need to see a cardiologist? And they'll let you know if it's something, there's nothing there grabbing me that, you need to see a heart doctor. You're absolutely right about wanting to get that that blood sugar down a little bit. There's certainly worse, but you want to get it down to that. You might want to ask them what your hemoglobin A1C is. I imagine they know. And if you keep that under 7, that's really good. Nothing itself in regards to COVID requires a cardiac exam. We're seeing patients referred that have been symptomatic or have continued chest pain, and then that's a whole nother webinar.
okay, all right. Thank you. The last question that was sent in ahead of time, I'm going to read this, and I want to say to the person who sent this in that, we send our condolences about the story that you've shared. And the story is, a friend of mine died suddenly at 55, literally dropped dead. The autopsy revealed he had died of a cardiac arrest, not heart attack, and he had heart disease. He was so healthy. He was an endurance cyclist, thin, no drugs or alcohol, took great care of himself, but he never went to the doctor. What causes heart disease in seemingly healthy people? Will a normal physical reveal heart disease symptoms?
Yeah, I'm also very sorry. And there's a few things I think about. There's a lot of possibilities what could have happened. Um, again, we're talking about an 85% reduction, and there are times where, there the ball is not in our court, and we don't have that control. There's also what we've seen with, I've got a bunch of endurance athletes that I follow that have had disease. And I think what physical activity can do is delay what was going to happen, because there are people, rare, but there are people that get, your friend did not have blockages. I'm sorry, relative or friend, I forget, but was it brother?
Friend.
Friend, where, physical activity and living healthy can put someone that would have had coronary disease in their 30s into their 50s. Your friend did not have coronary disease. There are, I think, a lingering thing, endurance cycling, or what are the heart risk factors of endurance athletics, and their Afib is mildly increased. That would not cause someone to drop dead. SVT, that fast heart rhythm, is mildly increased. But overall, as one would guess, it's very protective. Interestingly, there is an increase in calcium in your coronary calcium score, and that's almost a protective mechanism, even though it's in others it may not be that way. So it sounds like your friend may have had a rhythm issue, and um, it's a horrific story, and they are rare, but when they happen, it, it's
They're tragic.
heartbreaking.
Yeah. Okay. Excellent. I'm going to call on Rachel. Rachel has been monitoring the chat. And Rachel, we've got about 9 minutes left. Have we got a ton of questions here?
We have 9 questions.
Okay, let's see. 1 a minute.
All right. What is the latest recommendations on aspirin?
Yeah. So if you've had a heart attack or stroke, then absolutely take what I do with my patients, check with your doc, 81 milligrams or a baby aspirin every day. I don't care when it is. There's a email going around on a specific time. It doesn't matter. And if you're over 160 pounds in my office, I recommend 162 or 2 baby aspirin. Primary prevention, meaning you've never had a heart attack or stroke, I don't recommend it. Diabetes, it's iffy because a lot of people think of that as a coronary equivalent. I take that case by case and often will do a baby aspirin there.
Thank you. When being treated for high blood pressure, is it inadvisable to do circuit or HIIT training?
No, it's recommended. Absolutely. HIIT training being high intensity interval training, which Rachel does a lot of. It's very good for you. It's why she's an exceptional athlete, and no problems with that. Just make sure your blood pressure is under control and go for it.
Are you feeling a little pressure right now? 2 for 2. We're good. We're good on time. All right. How does thyroid disease affect cholesterol, both HDL and LDL?
There is a relationship with everything, of course, and there is one with thyroid and the heart, and you do want to make sure that's in check. I think it's a really good point. It'll affect, in my experience, the LDL more than the HDL. And then there's all kinds of like side pathways if it's making you sluggish and you're not getting out and getting physical activity and things like that. But it's a really good point to make sure you know what your thyroid levels are.
2 quick genetic questions for you. How can we discover if certain diseases are inherited? One was on Facebook about how can we find out about high cholesterol, and the other on Zoom was related to electrical problems and tachycardia.
Yeah, so you're really going to want your family history of what the HDL and LDL are with your cholesterol. There's very specific genetic tests, I believe, that can check, but they don't really come into play, nor do I recommend you chase that down. I mean, it may be different in other places. Genetic testing for something like that where you don't need it, it's usually thousands and thousands of dollars. So I'm sorry, the electrical, is it genetic, or how do we test?
How do we figure out where that comes from, both cholesterol and electrical problems?
Yeah, so electrical, that's a pretty broad topic. I will say that it is very rare. If you have a rare syndrome that's been in your family, and that can travel, like Brugada or Wolff-Parkinson-White are a couple more of the uncommon ones, that you very well may want to get genetic testing, but the overall lion's share of arrhythmias are not near as heritable as we think.
Thank you. Are cardiac problems a complication of COVID-19 upon recovery?
There are some, but the good news is myocarditis is the one that we've heard a lot about, more at the beginning than now. One of the guys that trained me at Ohio State is following their athletes, and none of them, they had a bunch of them that had it. None of them have persisted. So there are definitely exceptions, but overall, I have not seen personally or heard about any lingering cardiac issues. Thank God.
Apologies if you've already covered this. I know we talked a lot about sleep apnea. The question is there a definitive way to diagnose sleep apnea?
The sleep studies are very effective. There are issues as people may not sleep as well outside of their home and things like that. But um, yes, it's very testable. And yes, I've seen many negative tests. So I know there's a thing out there that they're always positive. They're not. I've seen a bunch that are not.
Okay, great. Two more. Can DVT be dangerous?
Yes, it can. So deep venous thrombosis. Yeah. The concern is that it'll, the overwhelming majority are in our legs and not our arms. But the concern is that it'll go up through the channels, the venous system, and into the lungs and cause something called a pulmonary embolus or a PE. So definitely something to address. Very treatable, very treatable.
Thank you. I have one last question from Zoom. We've covered all the questions on Facebook as well, and I know Aurel will close us out, but there's been a lot of favorable comments coming from Zoom. A lot of gratitude to you for taking all of these difficult questions within the hour and giving us wonderful responses. So thank you from all of us. I will leave you with this final question, and then I know you and Aurel have something to close us out with. Can excitability or ADHD make AFib worse or life-threatening?
So first of all, I love doing this, so I should be thanking you guys, and we want these webinars to work. So I'm so grateful that you joined us. So I'm sitting on my patio and I'm loving it. So thank you. AFib is never deadly, so don't worry about that. Ironically, I had a patient today that took Ritalin that shouldn't have, and it put him into AFib. It was a temporary thing, but I'm sorry, I got all excited when I said I'm sitting on my patio. What was the question again?
Can excitability or ADHD make AFib worse or life-threatening?
No, I have not heard a link with that. It would be more with Adderall or Ritalin. Yep.
Well, David, I don't know how we did it, but we have 2 minutes to say goodbye. But again, my thanks to everybody for joining us. We know that one of your most precious assets is your time. So giving us a whole hour of your time, we could not be more grateful to see all of you, to see your names pop up. Thank you for the questions. And David, thank you so much for being so gracious with your time and answering the questions. And to Brian and Rachel, thanks for monitoring the other streams that we have been using. And we will put the recording out so that you can check back and see if you missed anything. We plan on doing these every other month. So we're looking probably around the end of May, and we'll cover different topics. We're hoping that our next topic will be on healthy aging. That was my personal request. So as David alluded, I've already had my first shot. So healthy aging is something that's meaningful to me. So we'll see, but we'll be in touch with you. We've loved doing this. And so David, do you want to say anything else or otherwise we can just all wave goodbye?
Yeah, I say we just wave goodbye and thank you guys. And maybe the one last thing is, this is a great idea by our team to do these webinars. So please let us know who you'd like to see on here. And so we take requests, and I think you're going to be really happy with who we've got in mind. And we would love to hear who you want to see. Thank you guys for taking your time.